risk? The quick answer is no, because pitchers are dialed in. They know what they're doing. They know how quickly they need to move. So the opportunity for a pitcher to get there and throw his series for that inning is not going to necessarily put him at risk because they're trying to, quote unquote, speed up the clock. Injuries occur, and we've had this discussion before. These athletes are so professional. They know what to do. They know how much time to take. And then the bailout is if they need time, if there's an injury, they'll call a timeout. So I don't think that necessarily is putting them at risk because we're trying to be more efficient with time and during a game.
The one thing that we've seen over the years, and I always go back to 2008 Kansas City Royals, that kind of started the trend of one-inning pitchers, and especially in the major leagues where guys will come out and they throw max effort. That's like the key phrase, it's max effort. Is this still a thing that no one's really, considered as why these guys are burning out, especially at the big league level when you're trying to hit 95 plus?
That's not working
for every single one.
How many pitchers can a team carry on their roster? 12?
Pitchers-wise, 13's max.
13. So, to your point, if they have that roster that they're going to be able to utilize and pull from the pen, they're not really going to burn through a staff of athletes and put them at risk. Those max throwers, the guys who are going to throw 3 pitches and get their athlete out, that's what they do. That's what they're designed to do. So a closer, how long is a closer going to last? A couple of innings? Maybe even
that's max.
That's
max.
max.
If you go 6 hitters,
right.
That's a lot.
So I don't think those individuals who are coming in and throwing in the high 90s for an inning or two, I don't think that they're necessarily going to be at a risk point. That's who they are. That's what they do.
Let's talk. We're talking to Dr. Robert Waskowitz, orthopedic surgeon here at the Bone and Joint Institute. Let's talk about Garrett Whitlock out the remainder of the season. And tell me about, these elbow surgeries. You do elbows, shoulders, knees. That's your specialty. Are we gaining on these injuries? Meaning, are we getting them back quicker? And are they staying healthier, or are they getting injured or re-injured because we're rushing them back out there?
Whitlock is a great example to discuss on a big stage, but then specifically for him. The big stage thing, the elbow is the risk point for a pitcher particularly, and it's during the late cocking and the acceleration phase of their throwing mechanics, and they put a tremendous amount of stress on the inside of the throwing elbow. That inside ligament, the ulnar collateral ligament, UCL, is the main stabilizer that allows the kinetic chain to work from the hand to the wrist to the elbow to the shoulder to the trunk. So back in the day, when Tommy John tore his ulnar collateral ligament and went and saw the guru back then, Dr. Job, designed this specific technique to do an ulnar collateral reconstruction. So I'm being really specific with words. Reconstruction. He reconstructed the inside of his elbow. Tommy John was one of the first guys who was able to return at that high performance level. So the procedure, Tommy John procedure, got that name. Fast forward. That procedure has a tremendous background, and it's been done over many, many years. The hard part about that procedure is the time frame to recover. So initially when they were doing it and Dr. Job had his rehab protocol, it was upwards of a year before they would allow that athlete to get back on the mound. Fast forward. We're now looking at Garrett Whitlock. Interestingly, he had an ulnar collateral ligament reconstruction performed by Dr. Dugas 5 years ago, I think, returned to his professional level, able to throw very effectively, but now he has another injury to that same throwing arm. What we're trying to do is not reinvent the wheel. We're trying to find a technique that is effective and allows for appropriate rehab and protects the elbow and hopefully gets that athlete back to performance. The new technique that's out there, this is a spin on the ulnar collateral ligament reconstruction. It's now an ulnar collateral ligament repair. Really important distinction, reconstruction versus repair. So with a reconstruction, you have to take out the old and put in a new. With a repair, you're taking the tissue that athlete brings to you and repairing that tissue. The current state of the art is this concept called an internal brace, where we use essentially suture tape, very strong, non-absorbable safety belt, if you will, and will repair that ligament and then supplement with this extra internal brace. The benefit to that is that you're using the native tissue that's there, you're not changing the anatomy. And the other benefit that this guy, Dr. Dugas, has is that his return to play has been shortened significantly. First and foremost, it's the athlete, it's getting them back, but he's taken that almost a year-long rehab, and some of his studies have shown that he's been able to get him back in 6 or 7 months.
Is this something he's always going to have in his body now?
Yeah, that's
a great question.
That's one of those things that we're going to carry with us. And suture material, some suture material is absorbable, so it's like magic. It'll melt over time, over the course of a couple of years. But if you think of the level of a professional athlete, you want to have that brace that's going to be in there and last. So you don't want it to dissolve. You want it to give the support. The other benefit to that is it is supporting the native structure that's there. So you're taking a belt and advancing the tissue, repairing it, but then you're supporting it with this extra brace.
Is this, in your opinion, going to either be an alternative, take the place of Tommy John? Or is this, how do we see this in the future, and how young are people getting these internal braces right now?
It's the next level, and we're lucky as surgeons, as doctors, because it's an evolution. We're always trying to think of the next best thing. First and foremost, patient care, patient safety. Do what we need to do to try and reconstruct the ligament however it's done, whether it's traditional Tommy John procedure or if you use this internal brace. It's a newer procedure, so the learning curve for it is very steep, and you have to train and be taught by the individuals who are the stars with this. So it takes a long time to understand tensioning of the tissue and how to rehab that. So it's not a very common procedure. I have not seen it done in younger athletes now, not in our Pop Warner leagues, not in our baseball leagues. It's just not that common a procedure. Segue for a second. It's applicable to other structures. So we're using this now for ACL injuries. We're trying to use an internal brace to supplement the ACL that's torn, not necessarily have to reconstruct the ACL, but do a procedure where you're using an internal brace and you try and keep the native tissue. There's studies out there that show positive results, but I'm show me the money. I need to see the literature that's going to show me that it's going to be effective.
Talking to Dr. Robert Waskowitz here from the Bone and Joint Institute, orthopedic surgeon. Okay, so you're coming off 8 surgeries today. Shoulders and knees. Ronald Acuna Jr. just tore his ACL again. I don't think it's the same one. It could be the other one. But my question is, if you tear an ACL on one side, do you here now, even with the rehab specialists, think that could possibly happen to the other one? Like, is an athlete more susceptible to tear both ACLs if you tear the original one?
The studies and the literature support that opposite side injury is a risk point. And we're still trying to figure out why. Is it the anatomy of that individual? Is it the sport of choice? Are they trained to the appropriate level? But our studies have shown us that, and particularly in it's gender specific, in a female athlete, we know that there's a higher elevation for an ACL injury. And we know that if a female athlete tears one, she is at higher risk for tearing the other one. And it's not that they're doing anything wrong. Right. It's just that's the way it is.
What about his injury? It was non-contact. He stopped short, tried to go backward, and it ripped. What is he facing? Originally, you're going to do the surgery, but how long will he be able to come back next year?
Revision surgery. So if someone tears their ACL, has it reconstructed, gets back to performance and able to do what they need to do, there is a risk that is almost back to the normal risk parameter for tearing that native ACL. And it's not that they did anything wrong, it's that they were able to get back to performance. So if we can tune up that engine, let that individual get back and do what they need to do, there's always a risk. And it doesn't necessarily put that knee at risk if they have an ACL reconstruction and are able to get back to their pre-injury level. The hard part next for him is what's he facing? Because a revision surgery, if you tear your ACL, it's a primary procedure. If you tear your ACL graft, then you have to revise that graft. You have to use new tissue to make a new ACL. So a revision ACL takes longer to rehab, and the results, although still very good, are not as good as the first time.
I've really come around to be a Kyrie Irving fan in the last couple of months. Man, I was a Kyrie Irving hater about 3 years ago when he was on the Boston Celtics, and I was screaming, don't get this guy on your team. He's going to be a problem in the locker room. Plus, he's damaged goods. I remember 3 years ago he had his thing in his knee, like this metal band they had to take out because it was infected, and they had to put it back in. It's like, man, I don't want Mr. Tin Man being my point guard. But now the dude's doing great, and it doesn't look like he has knee problems at all. It seems like that procedure, whatever the heck that is, really worked for this guy.
He's a great example of having resilience and mental focus to be able to get back and play at that level. And the idea of someone who's had a surgery in the past, and are you going to take that individual? Do you want that person to be a part of their team? Are they going to be competitive and contribute to that team? Well, here's reality. Show me someone who hasn't been hurt. Show me an athlete who hasn't really been down that road and recovered from an injury, whether it's surgical or not. So Kyrie Irving, if they had a procedure and done to maybe repair a meniscus, do a procedure to stabilize the knee, sometimes we have to use implants to hold tissue in position until it heals. And to our point that we discussed before, once a tissue is supported by an internal structure, that structure kind of stays. So then you have to think of an idea of, well, is this a foreign body that's around a joint? Is it going to irritate the local tissue? So the treatment there is you try and rehab that individual. But if that is the focus point that's not allowing them to get back, the concept of a quote-unquote cleanup, going in, smoothing the rough surface, taking out what needs to be taken out, is an opportunity to tune up the engine again. So you're seeing the results of that. He is a competitive, effective player.
All right, we've got the Travelers Championship coming up, and these guys have bad backs and shoulders and elbows and things like that. You're going to be out there. Bone and Joint Institute will be out there. What are you looking for to get these guys through even just a weekend tournament?
It's a great opportunity for me to be a part of that, because these individuals are coming off of competitive tournaments, one after the next after the next. My point is, they are tuned. They are coming into this not with necessarily an injury and not necessarily at risk, but my job, our job, is to try and facilitate and manage and try and get them through this experience. I look at it as overuse type injuries. It's not a common thing, although we see it occasionally. It's not a common thing to have an acute traumatic injury on a golf course, unless you misstep and you dislocate your ankle or
Tony Finau.
Something that is an aberration. So our job is to try and manage these individuals. We have a full setup on site where we can do our training, treat, evaluate, and facilitate these individuals. It's an opportunity for me to kind of be part of the solution and not part of the problem.
How much of you guys existing, Bone and Joint, Hartford Healthcare, the world-renowned doctors that you have, how much does that help the Travelers? And you could toot your own horn to actually getting the PGA to keep coming back to Cromwell because of this facility, because of the doctors on hand that we have.
It's a template. It really is. And you have to have the right people in the right places. So a tournament like the Travelers coming to our wonderful facility here, we have the staff. If you look at where the tournaments are internationally, there is always a backbone that's supporting that structure. They always have medical staff. They always have the training staff. The PGA travels with their trainers. They travel with their trailers where they can do on-site treatments. So if you have the right people in the right places, then you're going to be able to facilitate. And, the best thing for me is not to have to do anything. I get to watch.
Robert, always a pleasure to have you on the show.
So
Thank
true.
you for letting us pick your brain.
Yes,
we appreciate your time.
Pleasure to be here. Thanks, guys.
All right.